My name is Claire Paquin, and on behalf of the Millennium Alliance, I would like to welcome all of you to the 2015 Healthcare IT Transformation Assembly. So welcome. We are proud to be joined by some of this industry's biggest and brightest executives, from the companies that drive business to the solution providers that enable them. Over the course of the next couple of days, you will be participating in thought-provoking roundtable discussions, stimulating one-to-one meetings, educational workshop sessions, and countless networking opportunities. So please take advantage of all of that while you're here. If you'd like to engage in our online social conversation, please use our hashtag HCTAssembly in all of your Twitter, Instagram, or Facebook posts. And now I am honored to introduce our keynote speaker.
Hi, Claire.
Douglas Goldstein. Hi, Doug.
How are you?
Good. How are you? All right, everyone, welcome Doug.
So we thought we'd do this before dessert, and then we can celebrate with dessert and whatever happens. There's a reception after, right, Claire?
Yes.
Oh, great. How's everyone? Great. Eric, how are you? Great. So I have some friends here. David Chow. David, where are you? You're out there somewhere. Back in the light. And Stan Huff, you're here. So Stan, how are you? We were just on a tweet chat the other night, right? So I call this kind of the pregame show. But first, so I've had a talk for about 10 years, digital doctoring today, genomic and nano doctoring tomorrow. But the genomic part is really today. So we're going to touch on a number of the themes I heard come out of the first roundtable that Stan was in. And we'll touch on hopefully some of the themes that came out of the other roundtables and challenges you're all working on. And then hopefully there'll be some humor along the way and a focus on some real things that we need as we move from a wholesale industry with a transaction infrastructure to a relationship direct to human industry as we go forward. So thank you for all coming. This is the pre-game show. So your participation is requested. So Stan and a number of CMIOs last Thursday night were on an hour-long what's called a tweet chat. And if you go to cmiochat.org, you'll see kind of record of the discussion, and that discussion was on interoperability. So I'd like to tee off tonight with a little bit of discussion and things that you all want to learn and explore over the next couple days. So the topic that was moderated by Louis Saldana, who's the CMIO at Texas Health Resources and hosted by Greg Masters, subject matter expert in ACOs, was interoperability. So I'd like to ask the question of your organizations, which of your organizations are delivering essentially real time? So when I said real time to my my friend who's a leading health IT architect, he said, "You mean within 7 nanoseconds of it happening?" And I said, no. So that term should be near real time. So are you in your enterprises today delivering real time scorecards on wait time in the ED or any clinical or financial operational factor? Eric, we were talking at Trinity. You're not quite there at Trinity, but at Eastern Maine, you had real-time report. So show of hands, how many organizations representing health systems, leading health systems, have what you would consider near real-time KPI scorecard reporting? How many think you'll have it? You can keep your hands up. Okay, this is part of the exercise tonight. How many think you'll have it in the next 1 to 3 years? Next 5 years? So for everybody, it's a goal, right? That we want to get there. Now, with the organizations that are doing real-time reporting and scorecards, did you build your own? Or did you use an analytics vendor? Or some of these other interoperability engines like Orion Health, Medicity, or InterSystems? Anybody using? Yes?
We have been able to obviously leverage some capabilities that we had in-house, including McKesson. We are an Epic shop, but largely driven by our own homegrown team.
Homegrown team to create in-enterprise operability and reporting.
Right.
Now, when we go out, the topic on the tweet chat the other night, Stan, was really how do we go outside the enterprise? But my sense is we're all trying to just do the blocking and tackling of getting real-time interoperability across all the different systems, across all the different hospitals we've been, Star Trek fans, we've been Borging hospitals. I mean assimilating, I mean acquiring, I mean integrating hospitals. So probably doing a combination of things. Like throughout my talk, I want to call out what I see some leaders doing in this area. So this is a no-wait ED scorecard for Christus. So Christus Health down in Texas has taken Teradata, Informatica, and MicroStrategies. They've created a whole set of utilities, data extraction utilities out of Athena Health and many, many systems, and standardizing the data in their data model. So in essence, this is a quick, kind of simplified, it's not the IT architecture. They're interested in sharing. So if anybody has interest in how Christus has developed these real-time scorecards and delivering these KPIs, Mavis Gerlinghouse, the Director of System Business Intelligence, would be happy to chat with you. But they've created, they think their secret sauce is in a patient-centric data model and the schema of that data model that can bring the information into their normalized data warehouse, the quality engine and its cleaning methodologies and the extraction utilities out of multiple areas, and then feeding that up through the middle layer on Informatica and then MicroStrategies on the reporting layer. So they call CPOE, CPOM, and so these are the dashboards that are available to the clinicians and the managers of the different health system, different hospitals within the system. Now Christus has an interest of how do we help rural facilities delivering real-time KPIs. So that's one of the areas of direction, and how do we help smaller hospitals deliver the same kind of real-time business intelligence that they are. So that was the first pregame show, and we'll talk about genomics, and we'll have the second question a little bit later when we get into genomics. But you know, we have a lot of driving forces going on, right? Digital and mobile. Look, I don't know, I'm at least a 3-screen guy, right? So I got my notebook here, I got my tablet here, and I've got my mobile phone here, and if I was in my office or my house, I'd have a big screen TV there. So what are the communication preferences of the people we're serving? And so we have the digital and mobile revolution that's been dominated. Now we have personalized health, President Obama's initiative. We have nano, volume to value. You know, the funny thing is we think value, as we move from volume to value, it will get simpler. If you've seen one bundle, you've seen one bundle, right? If joints, some joints include prehab, some don't. Some include physical therapy, some don't. Generally, the bundles in joints are just around physician hospital services. But we know that 50% of joint outcomes is dependent on what patients do when they leave your care. Do they gain weight? Do they become sedentary? Their outcomes are not going to be the same as a patient who's active. So we have this volume to value transition. We have customer science. What do I mean by customer science? It's the understanding human behavior. So some people call it behavioral economics. You're driving down the street. You see a speed limit sign. It's a passive 35 miles an hour. How fast are you going? 40. Now, that's an interactive sign. If the sign becomes interactive and it's telling you you're going 40, how fast do you go? 39. Because Robert figures that 39 is not going to get him a ticket, where 40 might. It's a very conscious choice. But that's the choice, that's customer science. But it's a real-time feedback loop. So how do we take that real-time feedback loop? And folks like Social Wealth and other organizations are integrating that kind of data to provide real-time feedback to citizens as they work to change or improve their health status. That's customer science. Big data can be applied to customer science, but it's also clearly a huge part of genomic, personalized health and medicine, and then AI, artificial intelligence. So a question. I have Watson playing chess, and Watson's playing against a human chess master and another Watson. Who wins? The human and computer or Watson? All right. So thank you for your answer. And I think the first answer came here. So your choices are, would you like the caramel creams or the apples? See, the peer pressure, right? If we were alone, then you can have both.
Oh, okay,
but you can share those. You can share those.
I'm not sharing.
He's not sharing. Well, you play well at home and with the other doctors. Oh, what just happened? Look at this. 10,000 steps. Anybody who got 10,000 steps already today, stand up. Okay, anybody with a wearable device on that's tracking your physical activity level, stand up. Now, if we asked this question 5 years ago, would any of us be standing? And that's what our customers and patients are doing. I believe that my physical activity is the next vital sign. I also believe that my sleeping patterns are the next vital sign. The clinicians in the room may or may not agree with me, but the question is, how are you going to integrate that data into the electronic health record? So there's an analogy here. Is Ford a car company or is it a what? How many people would agree that Ford is a car company? A couple people. Ford actually is now testing they think that car buying could be a thing of the past. They're testing a smart e-bike, ride-sharing programs. Ford is thinking, why don't railroad companies run auto companies? Because railroad companies at the turn of the century were railroad companies. They weren't transport companies. So what Ford is thinking is that they're a mobility company. How do they enable, support mobility? And they're looking for business models through these different approaches, understanding the dynamics of Uber and some of these other factors. Well, I gave it away too quick. Beyond health or six, look, we're six systems that call ourselves health systems. And I would say that health is a direction, but what you really are is life systems. When you heal somebody or put them in remission for cancer or whatever the dynamic is, you're extending life. All the work that the health systems in this room are doing, in many cases, are extending life, helping people manage chronic diseases, and it's really a life service. Just like Ford is not a car company, but a mobility company, you're in the business of improving my health and well-being and my family and the community that I serve. And that's the mission. And I think life is a really important word that differentiates as we try to figure out this intersection of mobile, social, genomics, customer science, and big data in terms of figuring out how we serve the people today and tomorrow. So this was an image I developed with a team as part of the Medical Informatics 2020 book, and we had many of these interventions spec'd in 2005. I was wrong in a couple things. It was not a person-centered architecture, but it's really family and then a community. And how do we make impact and change in those dimensions? So we're going to focus a little bit on some of the digital solutions I'm seeing out there. The revolution will be digitized, article in the Washington Post. What is this song? Name this tune. Going mobile. Who said that? Thank you. Okay, are you with the house? Aurora. How many locations do you have? How many locations do you have? 275. 275. How many people have downloaded the Aurora app? 4. Okay, in an era of mobile, here, thank you for sharing. So this is, if you haven't read this book or seen the PBS series, The Emperor of All Maladies, it's about cancer and the revolution in cancer and personalized care. Thank you for sharing, Scott. We need to change how we think. It is not the physical locations that will determine the success of your organizations going forward. It will be the number of people who download not just one app, but I predict in 5 years that your organization will have an app for new mothers, probably the kids at 5 years old, seniors. You'll have an app ecosystem prescribed by your doctors and shared with the patients. And you'll be measuring your success not in physical locations or visits, but the number of people who have downloaded it and the amount of interaction you're generating from that app. These are not new trends. The quantified self movement, Wired magazine did this article in 2009. That was 6 years ago. So what we see is a rapid growth of wearable businesses moving to multi-billion dollars. But as we all are asking ourselves the question of how we engage people. And my answer to you is you can't. What you can do is figure out how to interact with people. Just like you're texting, right?
I'm not texting.
Oh, he's checking his Fitbit numbers.
My Fitbit number.
These are addictive devices, right? And we can.
You told me to tweet.
I know. I'm glad. Thanks.
Welcome.
No, the point is that they're addictive devices. We have to figure out how to put things on those devices of the people we serve that they'll want to use on a daily basis. And maybe it's assimilating the Fitbit data into their personal health record and then providing them additional information. But in the process, you will be successful if you remember that what motivates people is fun, fashion, and friends. The 3 F's. Now, I spent 2014 in Ascension Health looking at these spaces. Virtual health, telemedicine. How do you build the infrastructure? So, all right, we moved from inpatient to outpatient to home care, but many of the people we serve are very mobile. So it's really anywhere care. So how do we do anywhere remote care management? There's a space that I call digital doctor extension services. So companies like HealthLoop or Conversa, Cognito, there's dozens of these companies. Some of them have an emerging evidence base and others don't. They're working to develop it. So we don't have enough primary care doctors, correct? Or allied primary care associates. Are we going to train them in time? So we're going to have to figure out how to substitute and partner technology and artificial intelligence with the clinicians and the care team and the social folks as we move forward. I will tell you, and this is my overarching message of this talk, Baycare could be the exception in this room that I know of, but there are probably others. You're going to need a next generation health information technology infrastructure that can do what consumer products companies do, that knows me as a person, that aggregates multiple data sets on me, purchasing behaviors, vulnerabilities. This is a key direction for all the IT organizations in this country that are seeking to move from a transaction-based model to a relationship-based model. So some of the companies in this space, and they're just a handful of examples. So Walter Kluwer spent a bunch of time and money. They built a platform, a cloud-based platform. They're building multiple modules around CLABSI, sepsis. And they presented this at HIMSS. So their sepsis module at Huntsville Hospital dropped sepsis mortality on med-surg floors 53%. Cloud-based solution, integrated. They can fire their BPAs through the Epic system or direct to any mobile device a nurse has. Zipnosis is a very interesting company. This is the iTriage, company iTriage. This is like your doctor's version of iTriage. Fairview Clinic was their start. This is an extension. Is anybody demoing or working with Zipnosis in the room? This is an extension of my doctor. So I'm not going to an independent triage app that will say, oh, you need to find a doctor. I'm connecting with Eric, your practice at Trinity, and it's providing assessment of 30 different conditions. And I may get a direct script because it knows me. I may get an appointment in the office, or I may get an outbound call, or I may be asked to call the office. So some of their results that they've shared is a 20% increase in PCP capacity, and they're documenting a trailing $82 per revenue per encounter. So we see other companies like LifeWire. This company was built by some entertainment guys who said, we know how to interact with people and generate their interactivity. They've got some case studies. They do a lot of work with wounded warriors on suicide prevention and a number of other categories. There's some early movers of PharmD. Tom Chamberlain started EdLogix. He's built a health literacy engine that adapts the content based on the literacy level of the person interacting with it. So you have a number of companies. In our roundtable, we talked about the end of life. If all these expenditures are at the end of life, how do we really address what people want? If 80% of the people want to die at home, but they're dying in the hospital, how do we encourage and support the end of life conversation? Here's an innovator founded by a physician, recognizing that this is the third rail of healthcare, and really developed a video solution. So recording through video, assisted video if you need an assistant or a concierge or a minister or somebody to support you or a counselor, really grabbing a video of the wishes of the parent or the child or whatever, the young adult, whatever, in terms of the dynamics. So you have a number of innovators that are developing solutions that various systems are trying to assimilate effectively to move forward. So I like to call out somebody that I really like and have been impressed with his work. This is Rich Milani, the Chief Clinical Effectiveness Officer at Ochsner. Now, if you follow his Twitter stream or some of the news, you know, Ochsner is the first in the nation to use, one of the first, to use the Apple Watch for bidirectional data sharing with his hypertension patients. Well, that's interesting and it's cool, but let me show you what he's doing that's really, really fundamental to managing patients within this electronic health environment that many of you have. In this case, it's Epic. So Rich is tracking patient compliance with medication prescriptions over time, and he's also providing an app prescription. So patient walks out with 2 prescriptions. Now, they don't have to go down to Best Buy to get their wearable device. They can stop at the Ochsner O-Bar, their version of the Genius Bar, and they can pick up their wearable, they can get instructed and get that information bidirectionally connected back into the clinic or the doctor who provided that prescription. Now, all that's very cool, but it's not the real work that Rich is doing. And he has an article that he's published, and it's up on the web, but I'm happy to share it with anybody. What Rich is doing is he recognized that Epic does not have what he calls a specialized individual practice unit. It doesn't have the kind of tools that he needs for managing chronic conditions, whether it's diabetes or hypertension or whatever combination of factors. So he's building with his algorithms and factors what he calls this next generation sitting on top of Epic. Now, when he builds it on top of Epic, Epic ends up owning it, and at some point it gets into their product roadmap and available to other people. So this is the real block. So the Apple Watch is sexy, but this is the real hard work that he's doing to say, how do I get my IT infrastructure and processes extended outside the 4 walls of the hospital? This is my experience with my chart. So my primary care physician just had my physical at Inova Medical Group. Inova is an Epic shop. Their entire stack's built on Epic. So I set up my chart. They told me my test results. I had my physical on Tuesday. They said my test results would be in on Friday, or Tuesday, 2 days. So it should have been there by Thursday. Today's Sunday. I've checked every day for my test results. Is my cholesterol above 200 or below 200? I want to know. It's not there. I was told 2 days it's not there. I sent an email on Thursday, where's my test results? No response back. Where's my referral for my colonoscopy? No response back. So my chart's great, but there's this other set of processes of patient, so they're not meeting my expectations that they set relative to when my test results would be there. Now, I was chatting with somebody, Daniel, right? Maybe they didn't check. Daniel, right? Where's Dan? There you are. Daniel, what'd you tell me? They might not have checked what box in Epic?
Well, sometimes the physician has to release them, so this could be physician issues, this could be an institution issue. It depends how they set it up.
Right, but you said if the physician, in your system, You said if the physician doesn't check within 48 hours, it's automatically released. So it's just thinking through how to use these tools. But the whole point is that these tools can potentially meet my expectations, but the customer service attitude that I'm a customer, I'm not a patient, that I'm a customer and that you need to meet my responses are paramount. So I'm going to focus a little bit on customer science and big data right now. Look, I've only managed to collect 100 megabytes of data on our customers. They're a really boring set of people. Within 7 milliseconds of a search you do on the web, that information's sold 3 to 7 times. There's an auto insurance company that is aggregating big data. What's your income? What's your busyness quotient? They're making decisions. Some of you may not have had an accident, but you got a raise in your premium. Not because the auto insurance company determined you're too busy to change. You have the income to support a higher insurance. Now that's a use of big data that I don't think is very human or customer centric. But so these big data sets, they're tools, hammers. I can use them to build a house or I can use them to tear down a house. Big data can be used to serve a customer or disserve a customer. But nonetheless, how many of your organizations are integrating external data sets on customers? Robert, you are at Hopkins. What kind of data sets are you bringing in?
Starting to look at social data sets from the state and so on.
Because we know that social determinants of health are critical to population health. My guess, I'm not reading your mind, but that's
Pretty good.
So we have the baby boomers, right? The next great generation, but there's more millennials than baby boomers. The things that we're going to connect with millennials about and the way they interact with their mobile devices are different than boomers, but there's boomers who behave like millennials on their mobile devices. So it's not just generational. And the frequent flyers, you shared in the meeting, the 61-year-old Hispanic female in the Bronx, I suggest, how do they use their mobile devices? It's probably texting. So you can probably connect and remind that patient through texting. Texting is the least common denominator across all these. It's not necessarily the app, but it's universal texting. How many people have read The Power of Habit? Who would like to read The Power of Habit? I don't know. Thinking of a number, I'm going to have to do this. I had 2 hands up in the front. See, there's a benefit for sitting in the front, right? So I'm going to share crowdsourcing with you. You've already got it? Power of Habit. Crowdsourcing. Now you just have to come back next year and give a book report. Who knows the Febreze story? What's the Febreze? Oh, you read the book. Listen to the audio. So the Febreze story is the product almost failed. So how the product was discovered. The chemist came home, smoker, came home, and the wife looks at him and said, "You stopped smoking. You don't smell." He goes, "I smoked 5 cigarettes today." But he was working with the chemical formulation. That led to the creation of Febreze. So the initial marketing campaign the product managers came up with Febreze was, it stops bad smells. So they did consumer testing. They go into the cat house that smells. They spray the cat house. Now the first formulation was scentless. And they said, look, we got rid of the bad smells. And the woman in the house said, what smell? She got used to it, right? So they went back, and when you make your bed or you clean up your kitchen, there's a little thing that happens to you at the end of that. It's a smile. I mean, you feel good, right? I just straightened up. You took care of a patient. Patient's happy. You smile. So what they did is they identified the habit and the cue. The cue is you clean something up, you straighten it up, you smile. So they turned it into a positive. Febreze makes you feel good. They added scents to it, and it gives you that sense of cleaning and that led to a blowout in that. So what we have to recognize, this word engagement is overused. What we have to take to our organizations is how do we interact with our people more frequently to help them do things that they want to do, like live to see their kids get married. So we're social animals, we're not rational, we're not going to be educated to patient engagement. We're not going to be educated to be healthier. We have to figure out what catalyzes each individual person to change that ingrained habit. We now have these data sets. So there's certain organizations that are taking these billions of data points and data sets. I don't know if you're tracking what Walgreens is doing, but it's pretty compelling. So Henry Leiter left Pro Systems or somewhere. He's now the chief medical officer. I can make these slides available to you with the link. We're not going to watch it now. I believe Walgreens is the next primary care hub based on what they're doing. They got an app, right? I can get an instant refill to my prescription. I can talk to a pharmacist 24/7. I can also get my cigarettes there. Not at CVS. I can chat, mobile apps. They have 100 million people participating in their Balance Awards. What that means is that people are activating their devices, they're generating points. Those points are redeemable for dollars. So Jane Saracen-Kahn generates $50 a month that she can use at Walgreens stores. They're adding in telemedicine to their Minute Clinics, or whatever their version of Minute Clinics are. You can get your digital health coach here also. I think this is the forefront. This is the gateway to many of your health systems. Walgreens, friend or foe, partner, they're doing things that can be replicated and patterns of interaction can be created with your health systems. Providence Health is one of those that is doing that. So they started a product development process. That product development process started with asking new mothers and seniors, two targeted groups, what they wanted. And what they found is that mothers wanted higher availability of triage 24/7. They also retrained that triage and the nurse advisor to deal with more lactation and other factors. So they're developing a whole specialized app for new mothers based on the primary research that they did. They hired a leader from Amazon. He built 3 teams, $150 million venture fund, their own digital development group, and their fundamental product development group. They're developing these apps for targeted groups like new mothers, the chief health officer of the family, and seniors. Primera, Washington State, also. Neil has built a database on everybody in Washington State. He's the director of member engagement. That isn't just about claims. It's about vulnerabilities, purchasing patterns, social demographics, communication preferences, personal values. How do I connect with people as people first? And he calls that the customer, and that we're going to know you as me. So genomic doctoring, they're giving me like 3 minutes. So I'll just put this question out there in terms of a cheat. If I just had my genes sequenced and I wanted integrated to my chart, which of your organizations could do that and then give me the best genetic counseling on how to deal with predispositions I may have in my genotype? How long will that be till we have that capability? Precision medicine. The interesting part of this diagram is moving from intuition to evidence-based to precision medicine based on a combination of human and algorithmic science. The book I've shared. We have a 200 million plus initiative launching precision medicine. We have organizations like Baylor, many of you in this room having initiatives in precision medicine. Partners has roughly a $10 million grant to look at the social and psychological implications of every baby getting its whole genome sequence at birth, and what could that do to improve health status, and manage conditions. Inova acquired the former ExxonMobil campus, 1.2 million square feet of fully furnished office space. They're rolling out a new cancer institute there, and their Translational Medicine Science Institute that's been around for 5 years will be moving to that campus. Now I like this, and this is sort of wrapping up. This is at-home testing. It's not quite genomic, but any male will be able to buy a home test kit, looks like, and the test kit will, all you do is put the sample in the spinner, centrifugal force, and it tells me my sperm count. If I'm trying to have more babies, whatever the dynamics is. Their social media site to educate people is called don'tcookyourballs.com. Excessive heat reduces sperm count, increases infertility. So they actually presented at Health 2.0. I interviewed the CEO. I found the humor compelling, and I thought the science, as diagnostic testing moves from a lab direct to your home, interesting example that we're going to have to figure out how to assimilate that information into our IT infrastructures. All right, smart diapers, right? Instant urinalysis, stool analysis, nutrition level. Do we really want that amount of information? I don't know, let's ask new moms. But the reality is that Huggies, so that was about artifact from the future about 7 years ago. Huggies rolled out Tweet Pee, so every time the child pees, it's going to tweet to you. So this is, if you can imagine it, someone's going to create it. Now, I'm not getting the urine analysis or the stool analysis, but I am knowing the diaper's wet. Some basic sensor data. Well, this is where we're going. I mean, drone care, right? That's the cloud. We have these invisible drones in the cloud. The reality is that drone care is something we'll be talking about in 5 years. So I'm going to close with, it's not just about their disease. As we talked about in Hopkins and what Robert's doing is social determinants of health. How do people want to be communicated with? What are their vulnerabilities? What are their health literacies? These are the things that's required for ongoing interactions with the people we are serving or we want to serve going forward. So my big close is the app is only the means. It's not about the app. What we're really trying to do is true personalized service in a consumer, citizen, human-centric form. But the challenge is that you're going to move out of, now that you've mostly got the EHR deployments in the core health system rolled out, your challenge is, how do I evolve from the transaction to the next generation relationship, womb to tomb sort of relationship, where you're my first call for help as a health system, whether it's fitness, health, healthcare, or medical care. So thank you for listening, and it's dessert time. Any questions while they're serving dessert? We can go back to the genomic question, or yes.
What do you think about patients like me?
Patients like me?
And the space that they're taking in their future role?
I like it because people are using it, right? People are voting with their information, they're sharing information, they're going there, they're sharing information across that social disease-centric network and trying to figure out what works for different people. And so I look at what people are using. They're using wearables. How are they using it? How can I then connect with them? They're using patients like me. How can I connect with them there or support them with additional information? Yes?
How fast do you think that genomics and precision medicine is really going to happen in this country?
I think it's happening very fast in certain areas. Every cancer has a unique, Eric, you're an oncologist, right? Correct me if I'm wrong, I'm not a clinician. I study what you guys study. Every cancer is unique. So what could be a prostate cancer in me could be a similar breast cancer in somebody else, right? So every cancer is unique. So the first area of personalized medicine is being focused on is understanding the specific type of cancer and how that cancer can be influenced through the different interventions that are being tested. So other areas, there'll be certain conditions that go higher in the priority, and it's going to come down to evidence, certain preferences of individuals. And I think there's a lot more social and ethical issues around understanding my genome than necessarily there is of the science, although cost right now, but as I understand it, whole genome sequencing will be down to about $1,000 a person very soon. It's already there. 500, 600.
Interpreting it costs $10,000, but running the biology.
Well, until Walmart's there to interpret it for me, right? Is that your new website, howimgonnadie.com? Other questions? Yeah.
Yeah, I have a question about wearables. I mean, one of the things that we see in our research at IDC is that 60, 90 days with a Fitbit and it goes into the top drawer. What's your thinking about how do we extend that and make the information useful? I think that's one of the challenges is, so if I do 9,000 steps, is that a good thing or a bad thing? And how do I make that useful and actionable information?
I think the examples, I think Walmart is doing it right. I think when you evolve, and it goes back to one of the earlier diagrams, I think when it's connected to my care team, right? So my guess is if you looked at the patients in Rich Milani's hypertension clinic, they're not stopping to use their Apple Watch because it's integrated to their care team. It's helping them manage their care. So it's the intersection. It's the one-on-one formula, right? Which is why we have to build the numbers on me. So it's really this. Different people have different mobile literacy. How many people game in this room, right? You're not gamers, right? You're not using your phones for gaming. But Arun Matthews, the CMIO down in Odessa, Texas, is a big gamer. He's using his phone for that. So what we have to understand, we have to get out of generalities and get down to the number of one. We need to understand that the Hispanic population you're serving in the Bronx will respond to text, not wearables. So we're going to have to build the profile of people's communication preferences. The reason why my first one got lost in a snowstorm, and I'm beyond the 3 months, because I'm finding it useful to keep up my daily activity, and I'm self-tracking, and I'm sharing it out through a social tweet, usually on a daily basis. So I have some social support. So I think if you take the populations that are using it over a longer period of time, you'll find that they have social support, or they're sharing the data with somebody else, or there's part of their employers as part of a contest. The people who are doing it as one-off that are disconnected from either a work, social, or health ecosystem are more likely not to be users because they're not finding it as useful, or that fitness information is not being fed back into my physical on an annual with my doctor.
Right here, Doug.
So many physicians have had to use the EMR in a much more impactful method because of meaningful use, so more clicks. So the question is, with all the wearables and all the other devices, maybe by show of hands, how many doctors actually want that information in today's world in your EMR? Do you want it populated with data elements coming from wearable devices?
Can I extend that? The doctor and the care team. So I would say, do you want your care team to know it? And I would moderate your answers as a group as you think about the answers to this, about if you're not just getting the raw data, but if you're getting the pattern, right? So if I have a consistent pattern of 10,000 steps and then I'm off for a month, would you want to know that I'm not active for a month? Maybe that's a sign of depression. Maybe there's an injury. Maybe there's a reason for an outreach. The same thing goes on with your diabetics. So if you think about that question, because we're going to have intelligence in the periphery, you're not going to see the raw data, you're going to see the trend data, and you're going to create rules and algorithms that says, oh, if I don't do 10,000 steps, over 3 days, a nurse may call me, or I might get an automated text to me saying what's going on, what happened to your physical activity. It shows that you care. Those are the kinds of things that companies like Health Loop and Conversa are doing post-visit in certain clinical conditions. So it's really staying connected 360/7 to your patients. So I think if you think about integrating this next generation of vital sign activity with the data you need, I would agree, you don't want the raw data. You just want the pattern that would affect the conditions that I'm trying to manage.
It's even more than a pattern. What I think, I mean, we can overwhelm with data. What I think clinicians want or could use is risk algorithms that lead to a risk number, i.e., we know you bought carrot cake at Safeway. We know that, your bike app hasn't downloaded your bike rides for the last 3 months, therefore your cardiovascular risk is going up by X amount. We can overwhelm people with data, but if you can give us a cardiovascular risk number, stroke risk number, a psychiatric depression risk number, because in a 15 or 20-minute visit, I don't have time to look at trends, I don't have time to look at reams of data, but if you can give me 3 or 4
Scores
that are based on good science and as much data as possible.
In the context, my context of what chronic conditions I'm managing, then that's useful for you. So you want the scores, the synthesized information. Yes?
Yeah, thank you. My name is Danielle Abraham. I am the Chief Data Analytics Officer in my system, and I am also an ED physician. My question to you, have you given thought about if this evolves, the unintended consequences of this, in a sense, the way I look at it is, I see patients in the ED that come in back and forth, in and out to the ED. And then one of the things that helped us a lot, we engaged a community agency. So one of the patients that we see often back and forth, we realized through our engagement and outreach that patient did not have basic things like shelter, electricity, running water.
Right.
The wearable and the technology is great for certain literacy level, certain socioeconomic status. My largest concern is, if we're going to call this personalized medicine, personalized meaning, is there a worry that because of our focus on this, we're going to unintentionally alienate those who are really poor, those who are really marginalized, those who are not really engaged in technology?
Well, I think that's the social outreach, right? So we have to figure out the bridges between our medical system and our social support systems and really understand in the context of the people we're serving. And that's the work that Premier is doing, that's the work that Hopkins is doing, and many of you in this room are trying to figure out it's not just about the wearables. You're absolutely right. It may be many homeless people have mobile phones. Lower income, it's a ubiquitous device, and the component that's ubiquitous is texting. So it could be, and there's a lot of research and development in companies, Text for Babies, a lot of work's being done internationally around the power of texting to let people know you're there, you care, and getting dialogue back and forth through that text medium. LifeWire is doing that as an example. Companies, Tiger Text, many other companies, Text for Babies, which is Voxiva, I believe, so Vocera, Voxiva. So we have to understand how different people can be communicated with and how to connect with them and build that into their profile, which goes beyond just their medical record.
So I guess my question is, has the industry moved past some of the fragmentation? So if you look at, say, mobile, you talked about having 7 mobile apps. Well, really, how do you consolidate that data? Same thing could be said for secure texting, where, I've got my single sign-on vendor pitching me on it. I've got my e-prescribing vendor as a module. You got direct out of both your clinical and your hospital systems. How do we get past that level of fragmentation? Because as a technology owner, I got to then blend it together. Why did we choose to go custom reporting at a small rural facility like mine? Because I couldn't get all the data I wanted out of all the various systems without doing custom reporting. And candidly, a lot of the reporting solutions vendors don't understand the business side of things. So how do we get past the fragmentation in the mobile, in the messaging, in the reporting spaces?
Well, that's a great question, and that's why we're all here at this conference over the next 2 days to really explore that, and that's not an easy question to answer. I think it comes down to a fundamental rethinking of our infrastructure so that we can build and assimilate multiple data and standardize that data across the people we serve or the people we want to serve. So I think that calls into how we think about moving from this transaction-based IT infrastructure we have to one based on relationships that can assimilate multiple data sets. And I think we have to look at ways that Netflix or Amazon and other people are building profiles of us through this data stream that we're generating from purchasing behavior, credit cards, use of mobile devices, and interactions with different services on the web. So it's really that data aggregation and integration. Some of the work that Christus and many of your organizations are doing is on the forefront of that, but it's really just the forefront of how to do that in healthcare and the fragmentation that it's not an easy question to answer. It's just a lot of blocking and tackling of doing those interfaces and aggregating that information into your data warehouse that knows me as a person.
One more right here, Doug, and then we'll take one more question after this and we'll wrap up.
So the companies that could know we are about to, I'm right here, the companies that could know we are about to get sick are not in the healthcare space. So they, let's say, 23andMe would know my genomic predisposition, and maybe Fitbit would give some information of mobility that relates to it. But a lot of the conversations we have, they are focused on the EMR as the repository of data. It sounds like this paradigm is there's going to be a dramatic discontinuity, that we will not be aiming at the EMR as the primary source of health information.
Well, yeah, I think there's a combination. We've built our infrastructure around the EMR that lives in health systems or doctors' offices. I know how to manage my bank account and financial information. Most citizens don't know how to manage. The best repository for all my health and medical and fitness information is me. But we have a population that hasn't grown up with health economics in school that says I'm the owner of my medical information. So we have this disconnect both socially in terms of education, predisposition. It's not like managing money, managing my health data. So it's a new skill for our citizens and customers to learn. And we have the dynamic that we've built the house of EMR from a hospital-centric or a doctor-centric basis and not a consumer. It's a big disconnect. And it's going to take 20 years or more for the population. And what we see, the quantified selfer is the one who says, I want my information. And that's roughly, it's getting up to about 20% of the population. And particularly with people with chronic conditions who are millennial or baby boomers, Stupid Cancer is an activist group, a nonprofit organization for people under 30 with cancer. These are some of the most active groups that will see it, but it'll take a generation or two for the paradigm to shift where I'm the owner, controller, and I bring you the wealth of information as a specialist if I've been diagnosed with a particular condition.
I have a question. Hello?
Yep.
You presented a physician prescribing an application, correct? A physician was prescribing an application.
Yeah, Oshner, correct.
And someone had a pharmacy of applications in the office. So the question is, if these applications have a therapeutic impact, do you think these applications should have a double-blind, randomized testing whether the safety and efficacy of the application? And if that's the case, do you foresee that in the future we're going to have, generic apps and brand name apps?
The answer is yes, and the answer is no. So it's yes, we should take a sample in certain groups and do the double-blinded studies, but this is not a pharmacological intervention, right? So Dr. Milani is tracking compliance with his wearable and app prescription along with the medication adherence data that he's gathering. It's not double-blinded, but he's tracking it in the context of what he's piloting and this new bidirectional interchange with the Apple Watch. So, yeah, we should take certain areas and do double-blinded studies, but the reality is that what I want as a consumer, the growth of the quantified self movement, the growth of wearables, yeah, some people stop using them, other people become sustained users. We can influence that ratio. It's a consumer demand. And Eric Topol and his work, The Patient Will See You Now, is on the forefront. This is not stuff I'm inventing. This is the stuff I'm seeing that people want. We want instant responses to our emails by our care team, whether it's by an intelligent agent or a care team. I don't want to wait 3 to 5 days for a response to my email and my colonoscopy prescription. These are fundamental consumer demands. So we need to test it, we need to document it, we need to track it, not necessarily in double-blinded studies. We need to show the evidence like many of these companies are doing, but we don't necessarily need to apply double-blinded across the board, but maybe in select cases. It's time for dessert. Thank you.